We'd like to thank you all for joining us today. We're very excited to have Dr. Liu as our guest speaker to discuss ACEs awareness and best practices. My name is George Yagotic, and I'm the Training and Engagement Facilitator. As you can see, our agenda here is up on the screen. We have a couple brief introductions before we dive into the keynote speaker. And again, as I said before, this is a small group. We want to keep this a dialogue. We want to make sure that any questions you may have are brought to the table. We want to make sure any comments that you have are brought to the table too, because this is best practices. We want to share those, what works, what doesn't work. And this is regarding ACEs screening and best ways to get that implemented. So that's our bottom line goal for this session. We are going to have a roundtable discussion after Dr. Liu finishes her presentation at 7:50. But again, please don't hesitate if you have questions or if you have comments in the moment to bring those up. Dr. Liu had mentioned she wants this to be more of a dialogue as opposed to a singular presentation all the way through. At 8 o'clock, we are going to have resources available from 211 Kings County. That'll be a short presentation given to us by Erica Lopez of Kings United Way. And we will wrap up and finish this at about 8:10. If you have to leave early, please let us know, and we can give you information about Kings 211. But that is going to take us to 8:10. So the meeting is just a little bit longer than an hour. Just a couple notes. We are recording this session. Karina, I didn't let you know, but thank you. We are recording this session. It will be available online afterwards. If you're attending remotely, please make sure your Zoom microphone is on mute. If you're having issues with connecting to the webinar, please call in and mute your phone. I already mentioned everybody to introduce yourself in the chat feature so we know who's here. I think it's important that everybody is familiar with who's here, with what organization you're with, and maybe your role or your intention for being here today. We do want to keep this as a way for people to connect and to maybe make some new connections. Lastly, please make sure your Zoom name and ensure that it's correctly spelled and identified accurately. Pronouns are good. I'd like to start off by introducing our ACEs Aware Kings County collaboration. With funding from ACEs Aware Kings collaboration is a collaboration of California Health Collaborative, Kings County Department of Public Health, Kings Partnership for Prevention, and Kings United Way. We very much appreciate the work of all our partners who have committed to moving this work forward to improve the health and well-being of individuals, families, and the communities in which we live. So for the people who are here, we have a small group of people from the collaboration who are here. We have Linda Baggio, who is the program manager at California Health Collaborative. Myself, Training and Engagement Facilitator at the California Health Collaborative. For those who are not here from the California Health Collaborative, we have Daisy Lopez, who's our Senior Director. And the Kings County Department of Health, Everardo Legaspi, is our Program Manager, is not here. From Kings United Way, we have Erica Lopez, who is here, and Nanette Villarreal, who is not in attendance today. And finally, from KPFP, or Kings Partnership for Prevention, we have Karina Casares, who is here, and we have Cameron. No, we don't have Cameron Jones or Julie Lafee. Julie Lafee is the Executive Director, and Cameron Jones is the Communications Coordinator. So about half of our team is here. And to start off and jump into, the California Surgeon General has a bold goal to cut ACEs in half in one generation. And this effort is part of Governor Newsom's California for All initiative. Their mission is to change and save lives by helping providers understand the importance of screening for adverse childhood experiences and training providers to respond with trauma-informed care to mitigate the health impacts of toxic stress. And that is the goal for the California Surgeon General and the goal for this collaborative as well, in terms of what we are doing. At this point, I would like to introduce Dr. Sabrina Liu. I'm very honored to do so. Dr. Sabrina Liu is a clinical psychologist and a postdoctoral fellow at the UC Irvine Conte Center. Her scholarship focuses on understanding, addressing, and preventing exposure to trauma and adversity among children and families, particularly those from culturally diverse and underserved backgrounds. Sabrina has published and presented on ACEs, their assessment in primary care, and their links to health equity and resilience. Her works have also addressed community and mass violence, disaster, mental health, forced migration, racism, and child mental health interventions in low resource settings, both domestically and abroad. As a trauma-informed clinician, she has worked with youth in hospitals, schools, and community mental health centers. Sabrina earned her PhD from the Department of Counseling, Clinical, and School Psychology at UC Santa Barbara and completed her APA-accredited doctoral internship at Cambridge Health Alliance, Harvard Medical School. So without further ado, Dr. Liu. And we'll have a short technical switch as Dr. Liu brings her presentation up on the screen.
Yes.
Excellent. Thank you, Dr. Liu, for being here today. We're all very excited to hear from you.
I am excited as well. All right, let me just see. So can everybody see my slides? Just nod.
Yes.
Okay, great. Thank you so much. Thank you for the warm welcome. And thank you for having me. I've been looking forward to this talk. My overall goal is to give helpful information related to implementing ACEs in ACEs screening in primary care. So I think the way that this talk is focused, there is a primary focus on pediatric primary care, and I think also there's more of a focus on medical providers, but I hope it will be helpful for all types of providers and practices doing ACEs screening. I also want to acknowledge that there's a lot of information packed onto these slides, but I want to be mindful that it's 7 a.m. on a Friday morning at the end of a really stressful week on top of COVID. So just out of respect for everyone's time, I might move quickly through certain parts. And I want to prioritize, like George was saying, the opportunity for questions and discussion. So I'll just pause periodically, maybe to check in with George to see if there's been anything in the chat related to questions or comments. So this is one of the parts that I think we can probably go through pretty quickly, because I imagine most people are really familiar with ACEs at this point and why we care about ACEs in healthcare. So basically, historically, ACEs have stood for adverse childhood experiences, which have included these 10 different types of childhood adversities that you can see on the slide. And they were first identified or termed ACEs with a study that was done in the late 1990s by the CDC and Kaiser. But since that time, there's been a lot more research, and the cumulative evidence really shows us that ACEs are a major, major public health issue. First, because they're really common. So we know that about 2/3 of the US population has at least one ACE, and ACEs are more common among populations that have been historically marginalized. For example, populations of color or populations of low socioeconomic status. And then, of course, ACEs are really, really robustly linked to later life poor health, health and disease, health risk behaviors, and also things like lower graduation rates and academic achievement. And there's this dose-response relationship, meaning that the more ACEs a person has, the greater their risk goes up for these different outcomes in sort of an exponential way. And we now know that toxic stress is one of the major mechanisms through which ACEs are linked to these later life health outcomes. So we conceptualize stress on a continuum from positive stress all the way to toxic stress, where positive stress is what we consider the stress that's part of a normal, everyday, healthy functioning. So things like the stress that you might feel for your first day of school. Tolerable stress is stress that doesn't necessarily have any positive benefits, but it's time limited and we have the resources to overcome it. So something like experiencing a broken bone. And then toxic stress really refers to chronic, intense stress that's constant. So it's constantly activating our stress response system. It's constantly activating that flight or fight response to the point where that stress response system starts to break down and doesn't necessarily work in the way that it's supposed to anymore. And it impacts other physiological systems in our body as well, particularly when we're experiencing this toxic stress during developmentally sensitive periods in our lifetime or in our development. So we have evidence to suggest that toxic stress has been related to disruptions in our nervous system and in our cardiovascular system and in our immune system and in our endocrine system. So at this point, hopefully we're all on the same page that ACEs are a major public health issue, and that if we were able to identify risk for ACEs and for toxic stress early, we could really mitigate poor later life health outcomes and also a lot of health costs down the line. So the pressing question now is, how do we prevent ACEs? And today we're going to be talking about enhanced primary care, which is one way that's really been championed as an important piece of the puzzle. But I wanted to just zoom out for a second and highlight that it really is just one piece of the puzzle, and it needs to be part of this larger movement and cultural shift where we recognize the impact of ACEs on health. And we also recognize that ACEs are born out of deeply embedded issues in our structures and systems. And so to address them, we really need multidisciplinary collaboration and change across multiple sectors. So that's one of the reasons I think these different events that are happening with providers and people from different types of organizations is so important. And I think it's also important to recognize that if you are someone that's working on ACEs in primary care, you're not alone in this fight. And I do think that we are at a really critical point in history where there's heightened awareness of ACEs and a lot of enthusiasm for creating change in policy and in systems and structures. So I feel hopeful. Maybe I'll pause there and just check to see if there's been any questions or comments.
This is really great information. It's a good refresher. So thank you so much, Doctor.
Okay, good. Then let's just move right into talking about what we're here to talk about, assessing ACEs in primary care. So some of this information is going to be repetitive from whoever took the ACEs Aware Medi-Cal required training, but hopefully it will be a good refresher, as we just mentioned. But I wanted to start out by reiterating, why we think primary care is like such an ideal place to do the ACEs screening. So the first is that there's generally a trusted patient and provider relationship between primary care doctors and their patients. And that's really the exact type of relationship that you want if you're going to be introducing a sensitive and important questionnaire like the Adverse Childhood Experiences Questionnaire, which, to be clear, in case anyone hasn't actually seen what the questionnaire looks like, it's a set of yes/no questions asking about whether or not those 10 adversities that I showed in the first slide have occurred in this person's life. And then there's a couple additional adversities that they've added on as well. All right, there's generally, hopefully, continuity of care in primary care. So you can follow up and track ACEs intervention, which is so important. Primary care doctors are really seen as the health experts by their patients. Most often, that information coming from them is going to be perhaps taken more seriously than coming from anyone else. And then primary care practices have access to large swaths of the population that might be challenging to reach through other ways or other outlets. All right. We do have a good amount of research that's been done at this point on screening for ACEs in primary care, especially if you take what's been published in the academic literature and also program reports and white papers. So I'm pretty familiar with this literature, and what I have seen is that there's really a remarkable overlap in the conclusions that have been drawn. So I want to summarize those benefits for you on this slide. And like I said, I'm going to include academic literature, and then also I'm pulling from the Surgeon General's Roadmap for Resilience report and the National Pediatric Practice Community on ACEs pilot site program. So the first thing to note is that research has really looked at ACEs screening in a diverse range of patient populations, clinical settings, provider types, et cetera. So they've looked at, just for as an example, pediatrics and adult medicine, prenatal care. They've asked patients as well as physicians and MAs and trainees and nurse practitioners how they feel about implementing the ACEs screener. And they've looked in a lot of different types of practices: community clinics, academic hospitals, safety net clinics, et cetera. And like I said, diverse populations demographically as well. So the first thing that is actually pretty consistent is that despite this being a big concern about additional timing that the ACEs screener might take, it really ends up not being too much of an issue. And the screener is said to add on about 5 minutes maximum. And sometimes some providers actually view this practice as saving time down the line. It's also really, really normal and very common for providers to express initial discomfort about having to implement this ACEs screener. So people are uncertain of how to discuss a patient's past trauma. They're worried about distressing them, understandably. But the other thing that's pretty remarkable is that it's consistently noted by these providers that this discomfort dissipates with the practice of doing the ACEs screener. And when they start to realize that patients really actually mostly respond positively. Go ahead, George.
Thank you, Dr. Liu. Can you say a little bit about the de-identified and the identified screening tool, and
Sure.
how the de-identified tool can help with some of that discomfort?
Sure, yeah. And I think I have a point on that on the next slide, but so there's two options for the ACEs screener. You can ask patients to identify the individual ACEs that they've experienced, or you can just ask them to give a total score of the number of ACEs. And I believe that the Surgeon General's recommendation right now is to do the de-identified score for the exact reason that you're talking about, George, which is that the research suggests that patients, I'm not sure about comfort level. I imagine that they're more comfortable doing de-identified. Although I would argue that some people want their providers to know more details. But the research shows that patients are perhaps slightly more honest when they do the de-identified score versus the identified score. So that's the recommendation, but there is kind of some ongoing debate because providers also feel that they're losing important information by doing the de-identified score. So that's an individual decision that has to be made by different practices. All right, that was a great question. So this relates to this last point. This relates to the last point that I mentioned, which is that What we see is that patients really are overwhelmingly willing to complete the Asus questionnaire and often really grateful to be asked. And it's actually really intuitive to them when someone explains, like, your childhood experiences may be impacting your health now. They want resources and they want more information on ACEs and toxic stress and resilience. So it can be an empowering process as well. We also see that people feel like doing the ACEs screening will strengthen relationships, including the relationship between the provider and the patient, as well as if you're screening a child, it can sometimes strengthen the relationship between the parent and the child because of the conversations about challenging things that have happened in this child's lives that can come up as a result of the screening. One of the reasons that ACEs screening is thought to strengthen the provider and patient relationship is because it really improves the provider's understanding of their patient, as well as perhaps gives them more insight into what the best treatment approach might be with their patient. And then because of the nature of implementing ACEs screening, there's a natural need for practices to improve their referral networks and referral coordination. So you see this ripple effect that happens that benefits kind of the whole practice beyond just the focus on ACEs screening. And then finally, something that people in research have really emphasized is how screening for ACEs aligns really well with practices that want to emphasize whole person care with their patients, because it allows this emphasis and this explanation of how physical and mental health are really connected. And then the last thing to mention is that no studies that I've seen have reported any adverse events or safety concerns that have come up from doing this work, major safety concerns. There are still some unknowns from the research on ACEs screening that so I think it's really important that as we unroll implementation of ACEs screening across the state, we continue to do research and continue to improve our knowledge. So some of the things we don't know include what is the best measure for ACEs. So there's measures that are recommended by ACEs Aware, and those are clearly capturing something important. We see that people endorse ACEs. We see that those ACEs are related to later life health outcomes. The question is, could we be designing a questionnaire that asks patients these questions in a way that they answer even more accurately? Are there other adversities that we should be asking about that could also cause that toxic stress response that we're missing? So those are some of the things that this is not to say that the measures that we're using right now aren't helping. It's just a question of, are they the best ones that we could have? The de-identified versus the identified score is an ongoing debate. And since I already spoke to that, I won't dwell on it. Another question is, who should we be screening and how often should we be screening them? So again, I think ACEs Aware has specific recommendations to screen early and screen often, but I think we could get more evidence in this area to really tell us, does it make sense to be screening everyone? Does it make sense to just be screening people in certain age groups? And should it be every year, every 2 years, every month? These are the things that we still need to figure out. What is a positive screen and how many should you expect? So again, there's recommended scoring algorithms through ACEs Aware, but that's also got to be an individual decision. What score qualifies someone for certain referrals or resources or intervention? I think that's something that we're still figuring out. And then once we figure that out, we need a way for practices to be able to know how many of these positive screens they should expect so that they can make sure that they're adequately prepared to respond to those positive screens. We also know from the research that there's a number of key factors that really facilitate successful implementation of ACEs screening in primary care. So the first thing we know is that it is so helpful and essential to do trainings and topics related to ACEs and ACEs screening, and to do trainings with everyone in the practice, and to do them before ACEs screening starts, and then to do them often throughout the process, partially because there can be turnover in practices, right? So we know that trainings can increase buy-in for practice change. They increase people's comfort in doing the ACEs screening, and it helps to facilitate a shared language and understanding of ACEs within practices. This one is probably self-explanatory, but integrating ACEs into the electronic medical system improves care for a whole number of reasons. It helps streamline workflow, reduces administrative burden, increases efficiency, helps track ACEs and referral over time, etc. Workflow probably will be and should be developed iteratively. So it seems simple: screen, response, refer, but there's a lot of intermediate steps that need to be figured out, and every practice or every setting where this happens is going to be unique. So it's really important to go into the process recognizing that you'll have to tweak it along the way, and that's actually best practice, to check in with people, see how is this working for you, what could we do better, etc. And then acknowledging that engaging with ACEs and ACEs screening does present risk of burnout and vicarious trauma among providers that are going to be involved in this work, and trying to preemptively address this concern or equip your organization with tools. And then the last thing we know is that ACEs screenings really should only be implemented in practices that are jointly making sure that they have the resources and interventions available to provide to patients that screen positive or seem to be at risk for toxic stress. Because asking the questions and not having resources to respond to those endorsement of those questions, of course, is not a good feeling for anyone. And so we know that this is really an important piece for patient and provider satisfaction when it comes to ACEs screening. Any questions or comments? All right. So I want to end this section of the talk by just giving some reactions from providers who are actively screening for ACEs in primary care clinics. So these are from qualitative results of 2 different studies I've done, asking providers how they felt about the ACEs screening. And what I saw was that providers really were overwhelmingly enthusiastic. So this first quote speaks to what I was saying before about the benefit of strengthening the provider and patient relationship and improving a provider's understanding of the patient's needs as well. So this provider said, "The screening alone improves the quality of my understanding of the family's experience. It opens the door to talking about some things the family might need, but be afraid to ask or not realize that they can ask about it." Another person said, "We're asking, but we're also working with the family as to how we're going to resolve it or how we're going to provide resources. If you learn something about patients and feel like you can't do anything to help them, then that's not a good feeling. But we're able to do those follow-ups, and we're able to say, we learned this, but we're doing X, Y, and Z about it." So that quote to me is really speaking to what I was saying before about the need to have resources and referrals available for patients. This provider acknowledged her initial discomfort with ACEs screening. She said, "It's a matter of knowing why you're asking. If you're able to explain to the parent why, that makes you less uncomfortable. Beforehand, I thought, oh my God, I'm going to ask these really personal questions and horrible things for them to answer. But that was more my issue. When I'm in it, I see it's more normal for people. And that's across the board for parents and teens," because she was asking parents and teens. And then lastly, this one again speaks to improving understanding of the patient. So she said, "It gives insight into what the family needs, but is not presenting in the forefront. a lot of the time families are coming in like, this just happened and we need help. But there's so many more underlying things that have happened before that contribute. Right. So moving along, I want to now talk about actually the nuts and bolts of the ASUS screening in practice. So actually kind of breaking down the steps of what this might look like in a clinic. So of course, your clinical workflow is going to be developed iteratively, like we already discussed. Your scoring specifics are going to depend on whatever your practice decides, with recommendations from ACEs Aware as well. But the basic process, no matter what, I think is going to look something like this. There will be screening for ACEs, and ideally, this will not only screen for ACEs, but also ACEs-associated health conditions, as well as protective factors, to give a better sense of the overall clinical risk for toxic stress. And usually it's clinical support staff or front desk staff that give out the screener. And then either they will score it or the provider will score it. And then the provider will review it with their patient and counsel their patient based on the results in the appointment. And then perhaps do referrals after that as well. So I think it's helpful to talk through actually how you might, what you might say at each step of this process. So I have examples on the next few slides, but I also want to give everyone a second to think of how they might say it themselves. And you can jot down notes to yourself. If you're feeling bold, you could type it in the chat. Just because I think it's so important to have language that feels authentic to you, that feels like it would meet the needs of your patient population that you know best. So the first question is, how would you go about introducing and explaining the ACEs screener to patients? And this, of course, might not be you. It might be somebody else in the practice that's doing it, but I think it's still helpful to think about how you might do that in 1 to 2 simple sentences, maybe 2 to 3 sentences. So I'll give this example, which is we have some forms that we ask all of our patients to complete so that the doctor understands how you're doing. The doctor will answer any questions you have about the forms, and I'm here if you need clarification on instructions. One of the papers is called the Adverse Childhood Experiences Questionnaire. This form asks some personal questions and screens for health risks. If you could please review the statements and write down the number of statements that apply to you. When you've finished, return all the forms to me. I will place everything in this folder and give it to the doctor before you go in for your visit. So very simple and straightforward, but I think covering a few important points would be important no matter how you want to say this. So I think one thing is making sure the patient understands that everybody's being asked to complete this screener. It's not just them for whatever reason. That you're also explaining that the questionnaire is de-identified if that is the case, and that the doctor is going to be available to review and answer any questions with the patient. So then moving into the next step of the process, someone's going to be reviewing and responding to the ACEs questionnaire with the patient. So in terms of structuring this conversation, I think it's helpful to imagine 4 simple but effective goals. The first being, you want to use this conversation to increase your patient's awareness of the link between ACEs, toxic stress, and health. You want to let the patient know that they can talk with their PCP about these stressors, and that will naturally become obvious to them through having this conversation, I imagine. You want to link the patient to further resources and treatment, and you want to build safety and trust of the patient and provider relationship while you're doing all of this. And that's a really important piece because, of course, this is a challenging topic and it can come with feelings of shame or stigma for a patient. So there are ways that we can counteract those, the occurrence of that type of thing. And we can do that through really working on taking a strengths-based approach that centers the patient as the expert of their own lives and what they need in the moment. The acronym OARS from motivational interviewing, I think, is also helpful to keep in mind to structure this conversation. I think using these tools helps structure a conversation where you're meeting a patient where they're at and helping them feel comfortable and helping them define what they want to do in response to the information that you're presenting to them. So open-ended questions can allow you to personalize your conversation with a patient, and because you'll ask an open-ended question and they'll respond with whatever feels most salient to them in that moment. And so then you can really use that information to understand where your patient's at in this conversation. And then using affirmations and reflections and summary statements, this lets your patient know that you're hearing what they're saying. And it also helps them to clarify their statement because they're hearing their words back to them kind of in a summarized way. And that's also really helpful for conversations that can be stressful or dysregulating, like talking about ACEs for some people. So again, I've kind of broken down how you might structure this conversation about endorsed ACEs with patients into 4 simple sections. So the first being in 1 to 2 sentences, explaining to patients why you're asking about ACEs. And so I'll give everyone a second to think what they might say. And I can give an example. So one thing that you might say is, we ask about ACEs because we now understand that exposure to stressful or traumatic experiences can increase the amount of stress hormones your body makes and increase your risk for health problems. Then you want to move into acknowledging and normalizing and validating the patient's ACEs experience. And one way you can do this is saying something like, when you filled out this questionnaire, you marked that you've been through some difficult things. Many people in our community have been through a lot. Then you can use your open-ended questions to open the door and allow the patient to tell you more. You could make this suggestion saying, I'm concerned that the stressful events you've experienced may be contributing to some of the problems we've been discussing. What do you think? And at that time, the patient might respond really enthusiastically, or you might get the sense that they're not really ready to talk about this any further. And that's also totally fine. Regardless, I think there's always an opportunity to highlight a patient's strengths at the end of the conversation. And if they seem open, then moving to provide further resources or referrals. So you could share with them some of the things that have been shown to reduce stress hormones and help the body heal include X, Y, and Z. You could pull on the stress busters that have been championed by ACEs Aware as kind of being the front line of intervention for toxic stress. And I have them on the next slide so we can look at them. So you could give some examples and then pick one that you feel like your patient has really excelled in, or if you've noticed another strength in their life, you could bring that up and say, you know, you've done a really good job at, I know that you've been working really hard on improving your sleep, and I think you've made so much improvement in that area. I'm really impressed. I would like to provide you some resources now or refer you to a specialist for working on improving your nutrition, or exploring mindfulness practices to help you with your anxiety. So I think it's important to remember they might not be ready for resources or referrals, and that's totally fine. This conversation alone is a major intervention with a patient. It plants the seeds for them to start noticing how they might be impacted by ACEs. It lets them know that their PCP cares about these types of stressors and is there to talk with them and provide resources whenever they might want them. And we know that even just sharing about one's adversity experiences, when it's done in a safe relationship and in a contained way, can also be a healing process for people. Right. I'll pause for a minute and just check in and see if there's any questions or comments. All right, great. So we've been talking a lot about resources and referrals, and I just want to make sure that everybody's aware of the many, many helpful resources that are available through ACEs Aware as well as other organizations. So there's tons of patient handouts on the stress busters that they talk about as being that first line of intervention. There's also guides on motivational interviewing and anticipatory guidance for people that are looking for more help or advice on how to structure these conversations. There's example workflows and treatment algorithms, like I mentioned. And there's also a whole lot more, including these tools that they suggest, Find, Connect, On Bertha, and One Degree. And people on this call might actually be more familiar with these resources than me, but these are all, to my understanding, tools that can be utilized to find various resources available in a patient's community, including a lot of different social services, which I think is so helpful and critical, especially at this time during COVID, where so many of our patients are facing other threats to social determinants of health, like housing concerns, money concerns, food concerns, et cetera. So,
Dr. Liu,
yeah.
If I could just share real quick, this is Kendra. So Unite Us is actually partnering with you all here in Kings. We are actually starting to roll out for the Kings, Fresno, Madera area. And we actually are an electronic referral closed loop system. So that's my role here. And so I have to jump off to go run my daughter to school real quick, but I just want to mention that we are your tool and we're really excited to be able to help support rolling this out. We're also partnering with the Fresno ACEs group. So we're really hoping that we can have some shared learning between the two counties as well. So Erica knows where to find me. Please tap me if I can do anything to support you all, and happy Friday. So
that's amazing. Thank you.
Thank you. Bye-bye.
That's very exciting. All right, great. Just another reason why these trainings and these roundtables and talks are so helpful.
Dr. Liu, I'm just wondering if I could throw a question out to either Shannon, Alex, or Carson. If you have used either Find, Connect, Aunt Bertha, or One Degree, any of those, has anybody here used one of those platforms? No, all new. Okay. Yeah.
So something important to keep in mind, but it sounds like there's other great resources.
I'm sorry, I have used Aunt Bertha, but Find, Connect, and One Degree I have not, and we use 211 quite a bit too, that Erica is going to be talking about here in a little bit.
Excellent. And what did you like about Aunt Bertha? What was something about Aunt Bertha that you really enjoyed?
I will admit that I tend to use Aunt Bertha when I can't find anything locally that I'm already aware of, because Aunt Bertha tends to have a lot of those national resources that aren't necessarily that doesn't have like a storefront or a person that like locally that can help me right away. So that's why Aunt Bertha's are really good for those, to fill in the gaps for some of the things that we may not have locally here. So that's what I've liked about that one. I will say at this time, though, I haven't really been able to use a whole lot of the resources on there because they tend to be very, very specific, and what I'm looking for needs to be a little more general. So I'm trying to think of an example. Looking for transportation that's not necessarily for a medical reason. That tends to be a resource that is a lot harder to find than just looking like medical transportation. I've got that down. I've got like 17 different resources for that. But we're looking for something that's not medically connected, but still very important. Those ones get a little harder to find.
Helpful.
And I'm sorry, Carson, you were going to say something?
Oh, sorry. I guess let's just disclose. I'm actually not a provider. I'm a grants coordinator, but so I wouldn't have used those resources before personally.
Great. All right. Well, I realize we're at 7:50, so I'll just share this last slide, which is just so that everyone's aware. I've included links to more resources on these slides that you'll all have access to. So these are some other really great organizations that I like that give, I think, really helpful resources. More sample parent handouts, more example scripts for this type of conversation. The CDC report from Preventing ACEs, which is where that table that I showed about different ACEs interventions at the beginning of the presentation, there comes from this report. And then toolkits from the American Academy of Pediatrics. And I did have a whole other section just touching on a few things like trauma-informed care and burnout and vicarious trauma, and also protective factors. But I just want to make everyone aware that I think that information will be available on your slides, even though I'm sorry that we won't be able to talk about it today. So I will stop sharing, and thank you so much.
Okay, thank you, Dr. Liu. So at this point, we'd like to turn this over to, or open it up for any questions, any thoughts that people might have with regard to screening tools and using the screening tool. For either Shannon and Carson, if you had any questions for Dr. Liu. No? And if not, we will go ahead and turn this over to Erica from 211 to give us a little information about Unite Us, or I'm sorry, not Unite Us, but United Way 211.
Thank you, George. Will you be sharing the slides?
Do you want me to share them? I think I could pull them up.
Yeah, let me see.
George, do you possibly have access to just share those slides, please?
Oh, there we go.
Thank you. Okay, so good morning, everybody. Thank you, George, for sharing those slides. My name is Erica Lopez. I'm the 211 coordinator at Kings United Way. We have Nanette Villarreal as well here in this slide, which is Executive Director of Kings United Way. So I'll be going over quickly what 211 Kings County is, as well as providing some resources that you can share with patients, clients. And I will also be talking about a project we are launching called the Community Information Exchange. So as you may know, 211 Kings County is a program of Kings United Way. It's a tool you can use to find different resources in the community. All 211 services are available 24/7. So we have different ways you can access 211. We have where you can dial 211. You can call 211 at any time, day and night. That does include holidays, and it is confidential and free to call. So you can speak to a live call specialist, and call specialists can provide information on local agencies providing services either verbally or can also text that information to caller. We also have, callers are also offered follow-ups to ensure that the caller was able to access services provided. So me and my team follow up with the caller if caller agrees to a follow-up to make sure that they were able to access resources provided to them and provide any additional resources that may be helpful. Maybe another need came up, or it's just a need in additional resources. You can also get information on resources by texting your zip code to 898211. When you text your zip code to 898211, you receive an opt-in message where then the opt-in message will ask you for age, gender, and reason for contacting 211. And then from there, with your response, the call specialist will then receive that information and then communicate with you through text message. We have a website available as well where you can search our database. It's called 211kingscounty.org. Where you can either search by text or click on different categories that will then give you information on different programs we have listed in the database. And we will also be doing a short demo on the next slide on the website. So we also have available live chat on our website. It's live chat and text message is fairly new. So we were really excited about that. And you can also search information on our database by downloading the mobile app called 211 IntelliFull. And so 211 IntelliFull is literally help at your fingertips. It's available in both English and in Spanish, and it is very similar to the website. It displays categories, subcategories, and you can also search by text. In the next slide, it's going to be a demo of how our website looks like. We upgraded our website or updated our website, and it's going to give you a list of the different categories and subcategories we have available.
Visit 211kingscounty.org and get information on resources available in the community. You can search for resources in our search by text. You can also chat with a live call specialist. Search through our category menu. Click on the category of your choice. Information on services in our database are available in both English and in Spanish. Get information on a service such as description, phone numbers, location, hours, and program delivery.
Okay, thank you, George. So for our next slide, I did add an image of a few different subcategories or categories and subcategories that I thought would be helpful. So we know the importance of being able to connect families and individuals to local resources. So these were the three categories I wanted to highlight. I thought that would be helpful. As mentioned in the website demo, we have a wide range of categories available on our website. So if you're looking to connect patients with local resources, please visit 211kingscounty.org. I definitely encourage you. And if you have any questions or if you would like more information on how to get to certain resources on our website, please reach out and I'd be more than happy to answer any questions that you may have. Do we have any questions? Okay. So going into the Community Information Exchange. This is a new project that we're launching fairly soon. If we can please go to the next slide. So the CIE is a community information, it's a community-wide referral system that facilitates connections across multiple agencies and links patients and their families to needed services. So it's a resource database. It has closed loop referrals, and we have the ability, or we're going to have the ability to share client level data as well. On the next slide, these are the core components of a CIE. So we have network partners, shared language, resource database, and bidirectional referrals, as well as technology platform and data integration. These core components allow network partners to work together, as well as share client records, access resources available in the community, as well as make referrals. So again, we understand the importance of sharing or information with other network partners, as well as making sure that resources are available and we're able to connect resources or patients with resources. So the CIE helps partners to collaborate and coordinate with each other, as well as making sure individual needs are being addressed. So overall, that is what the Community Information Exchange is. We are very excited to be launching this project. If you would like more information about the CIE and the platform we are going with, I have a link available that I can put in the chat box. We have a few different sessions. I was super excited to see Kendra here. She actually sent out an email regarding a few different sessions that they'll be having on the Unite Us platform. And if you have any questions, please feel free to reach out. Thank you.
Oh, George, we cannot hear you. If you could please unmute yourself.
Thank you, Erica, and thank you, Linda, for that. Appreciate that. At this point, I would like to make sure that everybody is aware that we have an evaluation survey. That evaluation survey, if I could ask Karina, could you put that in the chat feature? We will also be sending out an email afterwards with that evaluation survey link. I just want to stress and underscore the importance of that evaluation survey and how the information is recorded by ACEs Aware and used to see how we are getting this information out there. And it's very important that you get the evaluation done. So we really hope that you can take just a few minutes of your time afterwards to do the survey.
Okay, hold on one second, because I didn't have the presentation up, so I need to go to my drive and get it to get the link.
You want me to?
I can support you with that, Karina. I'll just post it in the chat right away.
Okay, thank you. Sorry, I was not prepared.
No problem.
Okay. And so that evaluation survey email will be coming out. Keep a look in your mailbox for that. Lastly, I'd like to turn this over to Linda to give us some information about saving dates that are coming up for our upcoming peer-to-peer and network of care sessions. Linda, do you want to tell us a little bit about some of the upcoming events that are happening?
Of course. Thank you so much, George. And thank you, everyone who were able to stay throughout the duration of this event. For our next session, for our peer-to-peer session, will be held on February 12th. We're hoping to host a speaker as well who will continue the discussion about ACE's best practices for implementation. If you have any providers who would benefit from attending and learning more about our event, how to implement ACEs, challenges, successes, and best practices, please be sure to extend the same Zoom link that you used to enter the session today will be used for the rest of our sessions for the rest of the year. We also have network of care sessions. So everyone in this room is equally able to attend that session as well. This is more community-based and not so provider-focused. With this network of care session, our next session will be held in January 19th, where we will have Tammy Cook. She will be discussing reconnection to resilience, and we're truly excited to have her there. I will be attaching the link to attend, to register for the network of care session here in the chat. So if you have the opportunity to, please do attend. And now